those and turn them in at the end of this event because our committee does review those. As you know, all sponsors of CME are required to execute conflict of interest policy. Dr. Bowman has disclosed that he has no relationships with commercial supporters that could be a conflict of interest. So it's my pleasure to introduce our speaker, Dr. Youssef Roman. He received his doctorate in pharmacology at Oregon State University and his Ph.D. in experimental and clinical pharmacology from the University of Minnesota. His research interests focus on cardiovascular pharmacology. He currently serves as Geriatric Services Clinical Pharmacist at Queens Medical Center, and he's an assistant professor with the Daniel K. Inouye College of Pharmacy. Please join me in welcoming Dr. Roman.
Thanks for the introduction. I'm really excited to be here, and thanks you all for coming. This is actually very special to me because I get to speak about something that's very personal to me, which is pharmacogenomics, and I'm really excited to share that knowledge with you. So before we get started, I just want to get a sense and do a pulse check here. How many of you learned something about pharmacogenomics, or heard about pharmacogenomics, or implemented pharmacogenomics in practice? If you just raise up your hand, if you have had those experiences. Oh, wow. That's actually pretty good. That's excellent. Okay, great. I mean, the field is relatively new, so I'm not surprised if not a lot of people were raising up their hands, but that's great. I'm very impressed. Alrighty, so we'll get started today. So this is the title of my talk. There's an emphasis, obviously, on the role of pharmacogenomics in the elderly patients. There's no disclosure, as mentioned. These are the learning outcomes. I think they were already listed in the flyer, so I'm not going to repeat those. Then we get into the overview of my presentation today. These are the major components of my talk, and hopefully to cover all of them. Just a background on the elderly population and epidemiology, polypharmacy. And then we're going to cover some of the challenges in geriatric pharmacotherapy and some of the implications of aging and how does that affect the pharmacotherapy. We're going to talk about pharmacogenomics and personalized medicine, which is a very important and very exciting time right now in medicine. And we're going to speak about some of the pharmacogenetic variants and studies that have been conducted in ambulatory care setting as well as in community-dwelling patients, and how common these variants are in the community in which we serve and which we work as well. And then we're going to close with some clear guidelines. It's called pharmacogenetic-based guidelines, or CPIC guidelines, the Clinical Pharmacogenetics Implementation Consortium, for some of the major drugs that are being used in practice heavily, and obviously including elderly patient Clopidogrel, simvastatin, and warfarin. Okay, so to kick things off here, I think it's important to talk about polypharmacy, which I know it's something that a lot of you, if you're a geriatric physician or work in geriatric, you can see that all the time. So polypharmacy is simply defined as the use of medication was not necessary, or more than necessary. And this is kind of the qualitative definition of polypharmacy. It's also defined quantitatively by the number 5. So something 5 or more that also includes non-prescription medication also qualifies polypharmacy. Polypharmacy, obviously, is very unique to some populations over others. One population that we know of, obviously, is the elderly population, and we see it to be almost prevalent, almost up to 50% of the population having polypharmacy. And to give you a better sense of how common is drug use in this population, clearly almost up to 90% of that population using at least one medication, prescription medication. So clearly something about this population that really needs attention from a pharmacotherapy management to better manage their care as well as their drugs. I know many of us here in the room really can sometimes have a hard time when we're prescribing medication for the elderly, because what we're trying to do is we're trying to de-prescribe, which I think is a good intention because we want to improve quality of life. But the opposite is true. Sometimes you have to have drugs on board in order to maintain adequate quality of life. So don't be afraid to prescribe something, but just make sure that you definitely give the right medication for the right purpose for the right patient. So to give you kind of overview about the elderly, just some statistics and some demographics. So the definition of elderly is 65, and that's sort of the conventional definition of elderly per the World Health Organization, and obviously across the board, across different countries. I know some people think this is pediatrics when we call 65, but that's the definition of the elderly. The population is clearly growing. We're expecting this population to make about almost 20% of the US population by 2030. We expect that population to be almost 39% of the population of the US by 2050. But that's not the point here. The point here, this is the population that's going to be using most of the drugs. So when you have a population growth like that, that means polypharmacy is growing, drug utilization is higher, which also require more attention and more mechanisms in place to help prevent some of these complications as a result of polypharmacy. So one thing about the elderly population also that we have to keep in mind, and this is a very heterogeneous population, from the age range, physical acuity, social status, financial status, health needs. It's pretty wide. I mean, obviously when you talk about adult medicine or pediatric medicine, you have more defined boundaries about the age range, what to expect. But when it comes to the elderly, you can have all kinds of things. So that's very important to keep in mind, that we're not treating the age, we're treating the patient. That's important to keep in mind when you treat elderly patients. And also that population, the elderly population, also comes with challenges. I think many of us in the room can have a hard time sometimes about how aggressive you want to treat these patients. Should you be on a statin for primary prevention? Should you aggressively treat A1C to establish? I think these are challenges that we always have a hard time with, whether this is something that's important, whether this is something that is needed. So we have these always debates and controversy around some of the medication. And that, again, highlights the gaps of knowledge and the need for more research in that area and as well as that population. So just to give you a better picture of the polypharmacy and age, this is, you can see it here on the x-axis, you can see the age range here. Obviously, this is the age range. On here, the y-axis is the mean number of drugs. As we can see here, as the age gets higher, the number of medications consumed is higher. So this is consistent with the fact that this elderly population definitely is more prone for this polypharmacy. But the polypharmacy in general actually is, we call it a bimodal distribution phenomenon. So what we see here, you can actually see polypharmacy at a very younger age, again, using the definition of 5 or more, and you can see that obviously at much later in life by having more medication. So it's a G-shaped phenomenon, if you want to describe it that way, but people like to say probably a U-shape. But either way, you can see it's a bimodal distribution. So there is here some that group, and then obviously in that group where we can see polypharmacy being common. So I think it's important as we talk about polypharmacy, we talk about some of the reasons why people who are 65 or older have taken or are taking a lot of medication, because obviously we see a lot of changes happening in the body as a result of aging. And I'm obviously not going to really read them off for you. I know some of you can definitely do a much better job explaining these things than I myself, but I think it's important to highlight some of the very important elemental changes as a result of aging to some of the body systems. And I'm just going for you here. So cardiovascular, I think it's important to recognize that the increased response to stress, that's a hallmark for almost all geriatrics, and obviously across the board, whether that's cardiovascular, endocrine, or any kind of system that we're talking about. And from a cardiovascular perspective, obviously we see the increased risk for orthostatic hypotension. That's a very common thing. And from the central nervous system, we see a decline in the receptor densities, and also makes it more prone for actually being more sensitive to a lot of CNS drug. So that's a very common thing we see in the elderly. And I think it's important, this is again from a drug perspective, is the gastrointestinal oral. We look at a decreased blood flow to the spleen and liver. Obviously the immunological implication of spleen, but the liver is definitely what I'm interested in the most, because this is where the action happens. A lot of drug metabolism happen. That results in elimination that might be decreased because if the blood flow is less or decreased. That means the extraction of drugs out of the plasma or the blood is reduced. That will also have implication on the kinetics. So the physiologic changes associated with aging clearly can happen at any point in time. But I think the profound effect happen at some points. So it's very important to recognize that there could be changes as early as 60, and it could be as late as 75. So I think when we talk about 65 range, that's not necessarily the point where we actually start to see these changes happening, but definitely can happen at early points at 60, and obviously it could be even before that, but it could be also happening later in life as 75. So the major things that happen in this kind of range group here is that we see major decreased imbalance and slow gain, and that's a problem because that's a problem we see to be a lot common in the elderly with the increased risk for falls, which are a pandemic in some ways. We also see changes in body composition as a result of aging. I think it's important from a drug perspective. Less body water, that's very important. They get easily dehydrated. Muscle mass is decreased, increased body fat, change in serum albumin, which also affect the ratio between bound and non-bound drugs. And finally, we see an increase actually in some other plasma proteins, such as the increased alpha-1 acylglycoprotein. So obviously these changes have implications because that's going to affect the kinetics and elimination and obviously metabolism for a lot of drugs, and that's going to be important as we dose these patients. But I think it's probably important to summarize those different changes and different physiological changes. And I think it's two major groups. One is that we have increased risk for major adverse events. That's kind of the bottom line. We see altered pharmacokinetics and pharmacodynamics of drug in this population based on these changes that happen in this group. And I'm just here summarizing. I think if you're taking notes, probably this is a good slide. This is the summary of all the pharmacokinetic changes that happen in the elderly at the different levels of metabolism, so ADME, absorption, distribution, metabolism, elimination. We see here, obviously, from an absorption perspective, we see a decrease in absorption, especially active transport, which can affect the bioavailability. We see a decrease in first-pass metabolism, which is related to phase 1 metabolism primarily, and that's tend to be lower or slower or reduced, and that can also affect the bioavailability for a lot of drugs that are being metabolized through the first-pass metabolism, and definitely can also affect if it's a drug, if it's an active to inactive, or it's a prodrug to active drug, can definitely vary a little bit. Distribution, as I mentioned earlier, we see a decrease in the body water content, and that can obviously have implications on the water-soluble or basically the water-soluble drugs. As you can imagine, you give a 25 milligram of hydrochlorothiazide and a bucket of 7 liters of water versus a bucket of 5 liters of water. Definitely gives you a sense of you achieve much higher concentration for the same dose given the change in the body composition. For the obviously fat soluble, we see the opposite is true. Obviously, there's much more fat than muscle mass, so definitely the drug that's a lipophilic tends to distribute to these tissues, which can result into much longer terminal half-life for these drugs. Hepatic metabolism, I already mentioned that earlier. We see a decreased blood flow to the liver, which can definitely result in a decreased extraction for a lot of these drugs that are blood flow dependent. So a lot of the elimination of these drugs tend to be almost backed up a little bit. And in general, I think it's to say that phase 1 metabolism in the elderly tend to be reduced. These are the cytochrome 50 enzymes generally. But phase 2 metabolism tend to be relatively intact. So that's kind of the summary of that. And finally, the renal elimination, I think we all know that with aging comes decreased kidney function. That means you gotta adjust the dose for renally eliminated drugs, especially if the drug ends up with active metabolites. So this is just a summary. So the summary of all the clinical implications of aging. So we talked about the decreased ability to respond to stress. I think, again, this is the hallmark for the geriatric in general. And that also results in atypical presentation with a lot of conditions. So with decreased response to stress, the patient presents differently than what we consider to be a typical response to medication or adverse events or disease. Obviously, we see a decreased system performance, and that's the whole idea of geriatric syndrome. Everything started to decline down or basically reduced. From a biological, physiological changes, we talked about altered kinetics, we also talked about altered dynamics, but also we talked about the possibility of having adverse events or drug adverse events as a result of these elimination or changes in elimination or metabolism. And finally, because of the fact that these all things are connected, you have much higher risk for developing comorbidities. The number of comorbidities goes up, which means more drugs on board, which means drug adverse events, and obviously problem of drug-drug interactions. So now we get into the more focus on the drug therapy, and now this is background information I presented. How do we treat these patients? That's the question. So I kind of summarized this, the way we treat patients based on my experience, and obviously based on the literature. There's two models. The first one is called the reactive model, or what we call the average dose model, which basically comes with a diagnosis. You give a drug therapy. Unfortunately, most of the time the drug doesn't work. Almost up to 90% of the time does not work first time around. And 30% of the time it does work. So that's a really big problem. But luckily we can always go back and we try to salvage something from those who failed and push them back into a more the desired outcome. So we can try to move patients from failed medication or failed therapy to the desired outcome. But think about those who end up being in one of these groups. Either hospitalization, disease progression, the intangible consequences of that, the physician-patient relationship could be affected as well. And obviously they're more unlikely to adhere to medication subsequently. So that's the problem with this kind of model. There's going to be a lot of patients who will end up going into one of these buckets. So would it be a personalized treatment would be a better option? Would that be something that we all like and we all wish to be the case? Because I would love to be that for me too. Okay? So knowing that the fact that a lot of elderly patients requires complex treatment regimens, I think a personalized approach would be more important because we want to do three things: minimize harm, we want to prevent disease progression, and obviously we want to improve outcomes. That's the goal of personalized medicine, and obviously personalized treatment. And the idea of personalized medicine basically exploits our knowledge of drug response biomarkers. So the idea here is that you want to identify a biomarker, and by knowledge or through the knowledge of this biomarker, you can make a decision based on that biomarker, whether that's the drug metabolizing enzyme or a transporter, or it could be the receptor. So what would that model look like then? If I start to exploit this information, what would that be called? So I called it the proactive model, or obviously the personalized dose model. So you start with a diagnosis, but this time you genotype them, okay, for those drug response biomarkers. And that will give you a better sense of what drug to use for this patient. And you select the right drug, hopefully, and look at the difference. It's not 100%, because we know genetics is not everything. There's so much more to that. That could be another CME about epigenetics and other things. But we can see a lot of patients move from this therapeutic failure status to the more optimized and more desired outcomes. And you can still always go back to this patient who failed, and you can transfer those from failing to more desired outcome by adjusting the dose, or doing some changes, and hopefully you get more patients to this desired outcome. And ultimately, we want less patients to go into one of these buckets, because we know the consequences of one of these can definitely be substantial in healthcare, and obviously on patients' health as well. So I think it's important as we talk about this personalized model. I think we need to think about a little bit about the heterogeneity of drug response, and that's why we think this is the future, and that's why we need to be more proactive about how we dose patients and how we prescribe medication. So the truth is that any drug can be poisonous, basically. It's just the fact that the dose, this is the father of toxicologists mentioned, this is all about the dose. And we see patients can take the drug and can develop mild to minimal, and some people can actually be life-threatening. Okay, so what's the story behind that? We also know that people of the same physiological characteristics receiving the same dose for the same drug, but develop completely different responses to any. So I'm sure somebody can relate to that either personally or from a clinical experience. So the reality is there's a lot of variability in how patients or individual or ourselves respond to medications. We also know that there's such an inter-individual variability response to drugs can be related to one of two things. Obviously, the activity of the drug the activity in the enzyme that metabolizes the drug, because these drugs ultimately gets eliminated, as I mentioned, the kinetics and dynamics. So if there's some sort of variation in the activity of this enzyme, will result in different levels and different exposure and different concentration. But we also know there's some genetic variation that also happen at the drug target itself. So there's some drug target may actually have a variation that make the patient more susceptible or less susceptible, and that also has implication on the drug dosage. We also note that the activity of this metabolizing enzyme or these drug targets are simply encoded by your DNA sequence. So what determines your activity and what determines your functionality is actually encoded by your DNA. And we know that we all have the same gene, we all just have different versions of the genes. And that's the word we call allele. So I have the same gene for hair. I may not have hair, but some do have hair, right? So the idea here is that we have the same gene, but basically we just have different manifestation of that gene. That's the point of genetic variation. And that's really the idea of pharmacogenomics. The idea of pharmacogenomics is that we have a population, again, a very heterogeneous population. And we want to stratify that population in a way that we can give the right group of patients the right drug that would work for them. And we want to stratify this population to identify the patients who should not be taking the drug altogether. And that's the goal, is to be able to identify who could be a candidate and who should not be a candidate. I personally like to describe pharmacogenomics as matchmaking without the hassles of dating. Think about it, right? You get matched right away. You just don't have to go through on a lot of dates. You just get it, nail it. So you don't have to go this trials and errors. And that's the idea of pharmacogenomics. And this is just, again, I know this is not the purpose of this talk to talk about genetic variation, but I just want to highlight some of the common genetic variation that we see in the population. Some of them can be very deleterious. It can be really bad, like obviously gene inversion. I'm just going to highlight some here. Obviously insertion, inversion, translocation. Obviously duplication, deletion also do happen in drug metabolism as well. But those are obviously not the most common type of genetic variation. We see a lot of these genetic variation in a lot of cancer patients. So they're definitely not the common type of variation. The most common type of variation that we see actually, that's what we call a single nucleotide polymorphism, which simply means that I can have the same gene on the first here, on the top, and then at the same position, I can have a different nucleotide base right there. So A, G, and T. So this is the same gene, it's 3 different versions of that gene. So we call a triallelic gene, means that you have 3 different possibilities for the same gene. So it's the same gene, just have different base at this position in that location. And that's the most common type of genetic variation that we see in the population. Okay? So this is what we were focusing on for the rest of our talk. But I think it's a good idea to cement what a single nucleotide polymorphism or a single nucleotide variation, just to cement that idea by giving an example. I think the example that seems to sound a lot of, basically more sounding and more relatable, and we probably learned a lot about, is the sickle cell anemia example, okay? So sickle cell anemia is simply, it's a change in a base right there. So this is the wild type for hemoglobin, DNA. All happened is basically a change from a T to A that completely changed everything. So if a normal person would have, on that position, would have glutamic acid, the amino acid. Once you have that variation, it ends up being this valine. And that completely changed the structure of the hemoglobin. You go from normal hemoglobin to a sickle cell type anemia. And that's really what happens. So this is, again, a very dramatic example, a more pathogenic example, but you can get the point, is that a change of a base at the sequence can have implications on the activity of that enzyme that's encoded by that sequence. Okay, so what is clinical pharmacogenomics? Clinical pharmacogenomics, again, it's using the person's genetics information to make drug selection, to dose the patients based on their genetics. And there's three different components of drug response. One is called pharmacokinetic genes, and those are genes that determines what the body does to the drug. That could be a phase 1 metabolism, like CYP19, CYP2D6, phase 2, UGT1A1, UGT2B7, and they could be also a transporter as well, responsible for moving things across. That's what we call pharmacokinetic genes. Pharmacodynamic genes is simply those are the genes that determines what the drug does to the body. So the opposite, okay? And that simply means the target, the drug target. That's what it is, okay? An example here is the VCORC1, which we know to be the drug target of warfarin, right? So that's the example. Or it could be an ATRB1, which is the gene that encodes for the beta-1 receptor, which is the target of beta blockers, right? I mean, you guys got that. And PCSK9, which is obviously for PCSK9 inhibitors, the cholesterol medication, the newest drug class that came up on the market. So as you can see here, that a change in these drug target gene can definitely affect how the drug works. And sometimes you might have to change the drug completely because of that variation, because the drug does not do well with this polymorphism. And the last kind of type of what we call drug response genes, those are the adverse events risk genes. Those are genes that are predicting your risk for developing adverse events, okay? And the most common type of adverse events we see, obviously it's more serious, more bad, worse, whatever you call it, is this Stevens-Johnson syndrome or tumor epidermolysis. Those are the very serious ones, and we know those can be predicted by knowing your genotype for HLA. So if you give a patient Ivacavir, for example, for HIV, or you give a patient carbamazepine for whatever indication, we probably want to do genotype the patient. In fact, Ivacavir, you have to genotype the patient prior to give Ivacavir. And carbamazepine, obviously, there are guidelines for that as well as the package insert. You should not give the patient carbamazepine in a specific population because of the HLA story. So this is the HLA in the G6PD, which is the glucose 6-phosphate dehydrogenase. This is important because it can predict your risk for developing hemolytic anemia. If you give the patient risperidase, which is a drug that can be used for management of gout or obviously for tumor lysis syndrome. And F2 and F5, those are clotting factors. But I'm not going to spend my time on these. So we talked about the different types of genes. We talked about the different variations. This is what we call the genotype. But now, this is what we call the phenotype. This is what the patient presents with. This is what you can see. This is what you can test. This is what you can observe. Okay? Obviously, the genotype, we don't observe the genotype. You have to test it. But you can definitely see the phenotype by the patient coming to you complaining, I'm drowsy, I can't walk, this beta blocker is killing me, I'm not even to stand. That's what we call phenotype, okay? So based on your genotypes, you can have nearly almost up to 4 phenotypes, but this picture here unfortunately doesn't do it good to tell you this what the third phenotype is, but there are 3 major phenotypes for any person for any specific gene. You can be a poor, you can be normal, or you can be ultra. A poor metabolizer, obviously in this case we're talking about a drug metabolizing genes, it means that you're actually accumulating the drug enough in the body that becomes super therapeutics. You're exceeding this therapeutic range because you have a poor enzyme that's not working well, okay? And that results in accumulation of a drug in the blood causing adverse events. You could be the normal person, which is the normal gene, normal function, and that results in a normal therapeutic concentration of a drug, and you get the right expected response without risk of toxicity or minimal risk of toxicity or adverse events. And then the final type or the final category is what we call the ultra metabolizer or fast metabolizer, if you want to call it that way. And in this group actually generally means that you have an extra copy of the gene. So you can have gene duplication. Remember I talked about the different genetic variations? You can have a deletion. So that could be an example of gene deletion. So the gene is not present completely. Or dysfunctional means that there's some activity. But in this case, the ultra metabolizer, you see actually gene duplication, where you can see the patient actually having not 2 copies, because we get 1 copy from each parent. You're almost having 3 copies, and sometimes it can be 4 or 5. An example of that, the story of codeine, if you read about it somewhere, that people can be ultra metabolizer for codeine, which can result in forming a lot of morphine, and there's some stories about that. but that's not the focus of my presentation today. So this is everything kind of a background to help us to get to this, really the clinical implementation, how pharmacogenomics and how genetic variation can all come into place and can that affect my practice. This is actually a case series that was published on 3 patients. Obviously, they're completely different 3 patients. They're not related by any means. These are the different demographics. As you can see, the age there and the ethnicity, comorbidities, heart, lung, typical comorbidities. And look at the number of medication here, 26 medication, 17, and 18, which I know for some people that's considered to be the normal for the elderly. But I want you to focus on the hospitalizations here, the counts of hospitalization, okay? 6, 23, and 2. Note that the patient number 2 had the lowest count of medication, but had the highest counts of hospitalizations. So what's that? So that's kind of really what this paper really tried to do, is trying to go back and genotype these patients and to look for some clues. Again, this is not a cause and effect relationship. This is again trying to, it's a hypothesis generating kind of study. So to generate some hypothesis, to see if there's actually some genetic basis for why that's the case for these patients to have a high counts of hospitalization. And what they did, they actually genotyped for what we consider to be the most important pharmacogenes, which means that those are the genes that encode the most commonly important enzymes that nearly metabolize most of the drugs on the market, including those one here on the far left, CYP2C19, CYP2C9 and VCORC1, that's actually what we call the Warfarin complex response. So this is what determines how well you're responding to warfarin. CYP2D6, sorry, my apology. CYP2D6, and finally CYP3A4 and CYP3A5. The percentage below each one of these are actually the percentage of drugs on the market that are being metabolized by these different enzymes. Okay? So this is not related to the patient, this is just for your own knowledge. So what I really would like to highlight here is I want you to really pay attention to this. So this is the case 1. This is what they found. They found the patient to be intermediate metabolizer. Okay, so there's some sort of reduced activity of those enzymes in CYP3A4, CYP3A5, primarily CYP3A4. And when they looked at case 2, they actually had the patient to be almost intermediate metabolizer for warfarin. And the patient was on warfarin already. This is plus sign warfarin. And case 3, the patient was nearly what we see to be the normal, and only had basically low sensitivity for warfarin, but the patient was not on warfarin, so it didn't really matter. So the point here is that this patient, obviously there's no way I can write the 26 medication on the slide for sure, but I can tell you that the patient, especially patient number 2, was taking a lot of medication that are affected by this, what we call rapid metabolizer or ultra metabolizer for CYP2D6, like carvedilol, which we know to be very important for, obviously, for heart failure in this case. So the patient probably was not getting a lot of benefit from carvedilol as a result of fast elimination of this drug, and that maybe resulted in some of these hospitalizations. So the idea here is that probably the role of genetics may explain some of the hospitalization that we've seen in those patients. Again, this is again to hopefully cement the idea that genetic polymorphisms, especially in what we consider to be important pharmacogenes, are very common in the community. Obviously in the community at large, but also in those who we serve as geriatrician or pharmacist or clinician in some way or some form. So this is actually a study that was done in Australia, genotyped about almost 2,100 patients, and they genotyped them for what we call, again, actionable genetic information, which means that if you have that genetic variant, there's some therapeutic modifications you have to make, okay? But that was just, again, exploratory. This is not necessarily looking at patient in the hospital being treated, no. This is just in general in the community. And just to give you a sense of how common these things are in community, and some of those people will come to your clinic for care, look at that. So look at the CYP2C19, 27% of the population had genetic actionable information for CYP2C19, 27%. For SLC01B1, which we know to be important with statin, 30%. CYP2C9, we had about almost 26% for the different variants, but about basically nearly about 26% in that population had this genetic information for CPC9. I think it's important to even highlight this. This is almost 61% of the population had genetic information or genetic variants in VCORC1, which means that if the patient has that genetic information, you have to make warfarin adjustment. Okay, so 61%. So obviously the story, I think I made the point here, is that this is very common. This is something that's already there. The patient has it, and one of those patients will come to your clinic and will be given a medication that could be affected by one of this actionable genetic information. Okay? So the other part of that study, what they did, actually, they looked at, okay, out of those who were known to have this actionable genetic variations, how many of them were taking the drugs that are being affected by that genetic variation? Okay, so that's a good question to ask. And look at this, obviously not substantial for some of the drugs, but clearly clopidogrel, which we know to be important for CPC19. So if you have CPC19 genetic variants, you should not be on clopidogrel, and we can talk about that later. But almost about 1% of that population with that genetic information were still on clopidogrel. That's a high risk right there. Homostatin, those who had some genetic variation in SLC1B1, which is the transporter for statin, 10% of the population with that genetic information were also on statin. The story goes on with warfarin and so on and so forth. So the idea here is that these genetic variations are very common in the community, and obviously a lot of patients with this genetic variants are also taking drugs that are being affected by genetic variation. So if that's something that gives us a hint on how to manage these patients, I think it's important. This is actually a case that I wouldn't say necessarily a real case, but it's just modified to get the point across. And again, to take what we talked about from the prevalence of the genetic variation in the community and how does that result in outcome. This is a case, obviously I'm not going to repeat it word for word, but this is the patient that presented to the ER, had made a rush to the cath lab, had a stent in place, and the patient was left to the hospital with the clopidogrel, and this patient comes back for another event of sensory thrombosis. If you notice anything in this case, I think you hopefully noted that. This is a Japanese patient, which gives you a hint, something about being an Asian and your risk for poor response to clopidogrel. So what happened? And could knowledge of pharmacogenomics have affected this outcome? So just a brief introduction for pharmacogenomics, or sorry, for clinical pharmacology of clopidogrel. Mechanism of action of clopidogrel, again, is antiplatelet, inhibits platelet aggregation. We use it in a lot of patients with obviously recent MI, SES, peripheral vascular disease. The metabolism, as I mentioned, is a CYP2C19. This is the primary metabolizing enzyme, and it results into the active form of clopidogrel, which is really the active form. That's what we want to get. 85% of clopidogrel actually is hydrolyzed, and that renders is inactive. So majority of the drug is inactive. Only a small fraction is being converted to the active. Elimination, nearly 50-50. The common adverse events, obviously, as you can imagine, it could be bleeding if you inhibit platelet too much, or if the drug is not working well, that's going to result in serious adverse events, obviously, like the drug is not working. So this is just a figure to show you the mechanism here. This is what we start off. This is the prodrug. Clopidogrel is a prodrug. It gets converted 15% to this active metabolite, and obviously the majority of the drug gets converted to the inactive by the carboxyl esterases. The two-steps process here, as you can see, predominantly by CYP2C19, step 1, and step 2 is also CYP2C19 mediated, which result into this active metabolite. What I want you to show you here is this: there are guidelines for clopidogrel dosing for patients who have genetic variants in the CYP2C19. So what we see here is that patients who have different genetic variation for CYP2C19, you can dose them differently based on the genotype. Poor metabolizer, intermediate metabolizer should not be on clopidogrel completely. You should be completely switched to something else. If you're normal or ultra metabolizer, you should be on clopidogrel or whatever you want to choose. But basically the idea here, you should not be on clopidogrel if you are poor or intermediate metabolizer. This is actually a study that recently completed that was done and led by a group from Florida. It's an interesting study. It's called Pragmatic Design, which they genotype the patient and they give the genetic information to the physician.
before the physician makes a decision about giving the clopidogrel or not. So it's up to the physician to make the change based on the genetic information. And there are 3 groups. One group is the loss of function, means that they have a loss of function for CPC19, but they would give an alternative. Non-loss of function, that means the patient has a normal function. And loss of function, clopidogrel, that means patient with loss of function, but remain on clopidogrel. And these are the cumulative MACE, the major adverse cardiovascular events. And we can see here that by comparing those who were given clopidogrel, despite the fact that were loss of function, to those who were given clopidogrel, though they actually, those who were given alternative to clopidogrel, because of their loss of function, you can see a significant difference in the MACE events. So knowledge of genotype clearly can obviously save people's life if you give them clopidogrel. So that's the idea of this example here. And then this is patient case 2, again to cement what we've been talking about, the different variants and their effect on drug response. This is related to the statin. This is this Caucasian female, given statin 40 milligram, comes back with muscle pain and aches and soreness and tenderness. And these are the medications she's taking, obviously consistent with probably high risk for statin-induced myopathy. But the idea here, the patient was given the drug, and what we see here is that everything is a normal limit, except CK level is slightly elevated. And the onset of symptoms consistent with the initiation of somatostatin, so this is what we consider to be a statin-induced myopathy. So statin, again, probably one of the most commonly prescribed drugs in practice. It's an angiopoietin reductase inhibitor, inhibits cholesterol synthesis, and definitely some other mechanism involved in there. Primarily metabolized by CYP3A4, so this is the major metabolizing enzyme. In order for it to work, it actually has to get to the liver for being metabolized, but also to inhibit cholesterol synthesis as well, because that's where the cholesterol synthesis happens. So if the drug doesn't work, probably it's not getting into the liver. That's probably the problem. Elimination primarily is through the feces, but also 13% through the renal route. Adverse events are myalgia, myositis, myopathy, and the most severe case is rhabdo. But that's something definitely is more serious. Just again to show you the mechanism, to appreciate the differences of how genetic variation can affect the response and obviously the side effect. So statin is taken orally. It's generally we'll call it prodrug. Gets metabolized in the intestine to form the hydroxy acid, which is the active, further metabolized to some other active metabolites. But that's not the point. The point is that it has to get to the liver. It has to be delivered to the liver, okay? And it goes through the portal blood vein, and that basically gets transported to the liver through some of these transporter here, and that's where the site of action as well as the site of metabolism. And I think of all the transporter, that's important, we'll call OAT P1B1. This is the major transporter for the uptake of statin from the portal blood into the liver. So as you can imagine, if this transporter is not working, where the statin is going to go, it's going to stay in the blood. And when it accumulates in the blood, where's it going to go? It's going to diffuse out to the tissues. And this is where you get the muscle pains, tenderness, aches, etc., etc. And this is, again, this is just to show you the differences of how people respond to medication based on their genotype for this transporter. This is obviously from a large genome-wide association study looking at the cumulative incidence of myopathy for patients with different genotypes. This is the SLCO1B1. This is the gene that makes the transporter. A T to C means that a T is changed to a C. So a T is what we call a normal, a C is the variant. And you look at here, you look at the cumulative rates of somebody with a TT and compare that to a CC. Substantially different. Almost nearly 10-fold difference of risk of developing myopathy. And to corroborate this, look at the patients who were given statin and measuring their statin levels in the blood and stratify that by genotype. Clearly you can see patients with a CC genotype had a higher concentration of the hydroxy or the somatostatin acid compared to those who are the TT genotype. So clearly there's something about this transporter that it does indeed affect how much you accumulate and obviously the risk of developing myopathy. And these are guidelines. Again, some genetic-based guidelines that can help you make selection about the medication, and that's what we see here. If you're normal, you give statin as normal. If you're variant, CT or CC, you can either do alternative medication, or you don't want to increase the dose more than 20 milligram of Singleton, and you got to monitor CK level. And then the final case that I want to present today that relates to warfarin, this is a typical case. This is African-American patients who presented to the ER with obviously symptoms consistent with bleeding. You can read the list of the medication. Obviously, she's taking one of which is warfarin. But I obviously want to highlight this INR here. This is INR 7. When they basically kind of interrogated the patient to know what's going on, she's taking ibuprofen, she's taking garlic, which we know to actually affect your bleeding risk, actually. So that's important to keep in mind. So good knowledge of pharmacogenomics, for this, especially for this patient, given the patient is African American, would have changed the outcomes. So this is Warfarin Pharmacology. This is, again, how warfarin is being metabolized, how it works. Warfarin is a racemic mixture. So there's S and R enantiomers. The S enantiomer is more potent. And that's where basically the site of action, the vitamin K oxyreductase complex. This is what's responsible for vitamin K synthesis. This is the target. This is the CYP2C9, which is the major metabolizing enzyme for S-warfarin. So if you have S-warfarin, it's going to get metabolized to 7-hydroxywarfarin. So as you can imagine, if this enzyme is not working, you're going to have a lot of warfarin. You're going to have a lot of inhibition for vitamin K. It's going to result in a lot of risk of bleeding, much higher risk of bleeding. And then another element of warfarin and vitamin K metabolism, what we call CYP4F2, which is an important endogenous enzyme that actually helps keep vitamin K in check. I think the best way to describe it is like your endogenous warfarin. This is like your endogenous warfarin, okay? So 4F2 is like your own warfarin. This is natural warfarin, okay? It helps to clear up vitamin K from the system when it goes out of balance. So as you can imagine here, any changes of these three major components can definitely influence your risk for developing bleeding or having a serious adverse events, or obviously the opposite is true, which may make the drug not working. So either way can go. And this is actually for the package insert for warfarin. If you pull up the package insert, if anybody does that anymore in these days, probably not. But this is actually guidelines by the FDA. And this is your knowledge of the patient genotype for CYP2C9 and VCORC1. You can actually make those recommendations based on that information. So the FDA has guidelines already related to warfarin. So if you know the genotype, you can definitely know their VCORC1. You can tell what the dose should be. At least gives you some sense of what the average daily dose for these patients. So that's just also something that's out there. And this is, again, obviously it's a very complex, it's a very case slide, but this is, again, the genetic guidelines for warfarin. The idea here is that if you know anything about the patient genotype for VCORC1 and CYP2C9, you can make recommendations based on that information. And it gets even more complex that if you know anything about their ancestry, you can get more sophisticated by making a more fine-tuning that dose adjustment based on their ancestry. So it matters whether you're black or not, especially for warfarin. And again, I'm not going to really read that because that's the point is there are guidelines for warfarin that can definitely help you to make optimal recommendation. And this is the final slide here. This is actually taking that guidelines and took these guidelines and test these guidelines. This is a study that was called the GIFT trial that recently completed by looking at patients who were hip or knee replacement, and they were treated with warfarin, and there were two arms. This is a randomized controlled trial. Patients who were genetically guided treatment and those compared with the clinically guided treatment. So they were given the warfarin based on clinical judgment, clinical dosing, and those who were utilizing genetic-based guided dosing. As you can see here, the outcomes, or one of the major outcomes, is basically looking at those who achieved INR of 4 or greater, which is a marker for basically a risk for bleeding. As you can see here, those who were genotype guided therapy were unlikely significantly lower than those clinically dosed warfarin. So clearly the genetic information can help at least prevent adverse events such as bleeding in patients treated with warfarin. And with that comes to the final here. So polypharmacy is very common. It's something that we see in the elderly predominantly. Heterogeneity of drug response is probably due to genetic variations in the pharmacokinetics as well as the pharmacodynamics. Personalized treatment approach for the elderly can provide better outcomes, minimize risk for harm. can help hopefully simplify treatment regimens, which we know to be a very challenging problem in the elderly because of the complexity of some treatment regimens. And pharmacogenomics is a tool to help provide evidence-based drug selection. Again, it gives you another edge to help you to make a more informed decision. You might make the best drug decision, but because of the genotype, it may not be the best decision ever. And to hopefully select the right drug with the right dose for the patient, especially for patients that are very prone to develop adverse events. With that, thank you for your attention. Hopefully I didn't go over time, and if I did, I apologize. And happy to take your questions. Question?
Any economic data showing benefit for screening?
Thank you for that question. I think the question is, are there economic data to show benefit? I don't have that data, but definitely there are data out there that to show that genotyping actually, especially for some drugs, definitely not all drugs, can be actually cost effective to do the screening before giving the drug to the patient.
These are issues with the payers, right? Paying for these tests.
Yes, that's true. This is one of, I think, basically what you're talking about, some of the barriers of implementing pharmacogenomics, which again, it's a whole new topic in itself. But yes, this is one of the barriers for why we're not seeing pharmacogenomics taking the practice by storm, is because of these pushback from obviously from the payers because they're not paying for it. But I can tell you that there are some third-party payers, especially for Clopidogrel, that are paying for that. The evidence for Clopidogrel is very strong that you can't ignore it anymore. Yeah. Especially when we talk about special population that we know they have a higher prevalence for CPC19 loss of function. More questions?